Assalamu alaikum, it's me Dr. Muhammad Qazafi and you are watching Dr. Muhammad Qazafi Views, and I am trying to explain you about little bit the progressive spastic paraparesis and decreased mobility in young patient. Actually this topic has a value in that regard when you are considering the pediatric neurosurgery and how these kind of patients, when they are coming and they are asking the questions, so do we have the answers for that or not? So it is a bi-purpose kind of topic which I want to present in front of you people. One purpose is that definitely it's information for the patients, and simultaneously it's a little bit of knowledge I want to share with our neurosurgical or neurological colleagues. So here there is a 49-year-old male is evaluated for intractable spasticity, and during early childhood the patient was noted to have a spastic paraparesis. However, he was able to ambulate until around 18 years of age, and his symptoms gradually worsened and he became wheelchair bound at the age of 30, and he was given a diagnosis of hereditary spastic paraplegia and was followed closely by a neurologist. And he takes beclophen, lyoresal 20 milligram tablet HS. However, higher dose of the have resulted in intractable sedation side effects. So botulinum toxin injections in the lower extremities have provided minimal relief. As we know, and as you know, I just want to present this case as an analogy, and definitely I will try to present the topic. And as I mentioned, this 49-year-old male evaluated in the intractable spasticity, and during early childhood this patient has noticed that, and this spastic paraparesis and you know that he was able to ambulate until the age of the 18 of age, and his symptoms gradually worsened and he became wheelchair bound at the age of 30, and he was given a diagnosis of the hereditary spastic paraplegia, and he was followed closely by a neurologist, and he taken beclophen and 20 milligram HS. However, the higher dose of this medication, you know that they cause intolerable sedating side effects. So that's why botulinum toxin injections can give, especially in the lower extremity, have some providing some minimal relief here. And past surgical history, and in this patient, the repair of the nasal septum, deviation in the early 20s, and his family history was the 5 paternal relative include in his father diagnosed with the hereditary spastic quadriparesis. So the social history works part-time, attending school with the intention of becoming a medical coder. Social history, if I may consider here, that the works part-time, attending school with the intention of becoming a medical coder, and after that he calm, cooperative male who appear of a stated age and no acute distress, oriented to self, date and location and context. So the severe rigidity and passive movement of the lower extremities and the knee were unable to be fully extend. So the sustainable bilateral ankle clonus and the lower extremity movement result in extensor spasm at hip and knee joints. If I may consider what should be the differential diagnosis, definitely a lot of things are coming in mind, definitely, such as that congenital degenerative hereditary spastic paraparesis, or the structural abnormality involving in the brain or the spinal cord, and we can say the mass lesion and compressing the spinal cord, tethered cord syndrome, cerebral palsy. So these are the congenital and degenerative disorders such as the hereditary spastic paraparesis and the structural abnormality involving the brain or the spinal cord. So the mass lesion, compress the spinal cord, or the tethered cord syndrome or cerebral palsy. If we may consider there is a vascular element, then it could be the stroke, or if we consider there is a infectious element, then HIV and the neurosyphilis, or we can say the traumatic brain or the spinal cord injury, or the leukodystrophies and progressive multiple sclerosis, or B12 deficiency, spinal cerebellar ataxia. These are the differential diagnoses in my humble opinion, and it could be early onset of the dementia, and dementia can present like that, especially when presenting at the early onset, and it could be the motor neuron disorders such as the amyotrophic lateral sclerosis or primarily lateral sclerosis. These all are very important differential diagnosis, and when we have to establish the diagnosis, we have to exclude this diagnosis here. Because as I mentioned you that this is an analogy topic, and we are choosing this topic which is very near to our original patient. So just for understanding or better understanding, so I took a picture from a book. I want to show you here one book, and you can see here, and this is the T2 weighted image sagittal section MRI with the brain, sagittal, and a T1 weighted image, and the cervical spine with T2 weighted image, and then thoracic and lumbar spine, and then I want to mention you. So here I want to mention that this specifically these figures, and you shown as the T1 weighted MRI of the brain and the sagittal T2 weighted image of the cervical spine you saw, and the thoracic and the lumbar spine demonstrating no structural abnormality at all. So here our differential will go, could be the hereditary spastic paraparesis with no additional hereditary spastic paraparesis associated CNS findings such as atrophy of the corpus callosum or cerebellum, or a white matter changes, so which is not very appreciable on the MR. So that's why actually these kind of patient, when it coming to us, we are trying to admit these patients, and routine lab definitely for pre-operative evaluation if we have to do anything, and I will mention what, then CBC, BMP, coagulation factor, and a metabolic lab to rule out the metabolic etiology, free T4, TSH, B12, VRDL, ESR. We are doing here, and definitely we need the consultation for the evaluation and optimization of the medical treatment of the spasticity, and from the neurology and internal medicine. If not already consulted, then typically patients are referred to the neurosurgeon office by a neurologist sometime, and after though the evaluation and the medical therapy has been exhausted. So actually these kind of patient usually sometime is coming directly to us, and sometimes they are coming from the neurology. So when they are coming directly to us, then we are taking the consultation from them. Definitely we have to take the opinion from them, from the neurologist also. And if these kind of patients are coming to them, they definitely taking the second opinion from us also. If there any chance we can do anything, or we want to do anything, or we could do differently for these kind of patient. So hereditary spastic paralysis is a category of the inherited disease. It is an inherited disease. It is very important to know that, because by name is mentioning the hereditary spastic paraparesis involving progressive fitness and spasticity in the lower extremities, and the symptom result from the axonal degeneration that primarily affect the distal portion of the corticospinal tract and to a lesser degree the dorsal column. Mild loss of anterior horn cell can occur. Inheritance can be autosomal dominant, autosomal recessive, or X-linked recessive, and more than 56 hereditary spastic paralysis loci and the hereditary spastic paralysis related gene have been identified. So other types of the spasticity typically result from the upper motor neuron or cortical spinal tract dysfunction, leading to the inability of the distal gamma aminobutyric acid receptor to correctly absorb GABA, which presynaptically inhibit the excitatory neurotransmitter release, and the affected nerve lack inhibition and stimulation target muscle constantly, and this result in tonic contraction and muscle spasticity. So this inciting upper motor neuron dysfunction can be due to intrauterine maldevelopment or perinatal cerebral injuries, for example the cerebral palsy, or secondary injuries such as the stroke or traumatic brain injury or the spinal cord injury. So, and the treatment options we have, what kind of the treatment option we have here, I want to mention, such as the treatment option like that, the medical, non-pharmacological, or I must say the medical or no pharmacotherapy definitely is known to reverse the effect of or halt the progression of spasticity, so that the drug therapy focuses on reducing the severity of the symptom and improving the physical comfort, mobility, and the quality of the life. GABA agonists such as the oral beclophen bind the GABAergic receptors in the dorsal horn to presynaptically inhibit the release of the excitatory neurotransmitter, and most widely used oral pharmacotherapy agent for treatment of the spasticity. Alpha-2 adrenergic agonists such as the tizanidine or nocturnal or intermittent spasm, and benzodiazepines, diazepam or clonazepam to decrease spasm intensity. So these benzodiazepines, diazepam or clonazepam or decrease spasm intensity, all are definitely involved in it, and we can involve all these drugs. It could help sometime, and such as the sometimes I'm telling that it is not an absolute treatment. It is giving some relief. It is not a treatment. It is giving some relief. It's some kind of a palliation. It palliates the cause or the symptoms. So that's why antimuscarinic, I want to mention here tolterodine disease and bladder spasms, or botulinum toxin, neurotoxin injected intramuscularly to affected areas. Physical therapy we usually do, and the surgical treatment such as the orthopedic operation for the contracture relief and to correct the joint deformities, and the beclophen pump placement and the direct intrathecal administration of beclophen, rhizotomy or mylotomy. These are very important things here. And for observation, the patient with the spasticity who are observed typically do not exhibit the improvement, and their spasticity can progress to the point where their mobility gait and the quality of life become significantly affected. So sometimes observation is also a kind of a management. We are managing the patient by observation. How the patient with spasticity who are observed typically do not exhibit the improvement, and their spasticity can progress to the point where their mobility, gait and the quality of life becomes significantly affected. And the surgical, as I mentioned before, that the orthopedic surgeons, then they can help to release the contracture and correct the joint deformities. So beclophen pump placement usually we are placing as a neurosurgeon, and the direct intrathecal administration of the beclophen help somehow to the patient, rhizotomies and the mylotomies. Actually, I want to mention here again, there is not a complete treatment. I am mentioning that we as a neurosurgeon cannot provide the complete treatment. Yeah, definitely when we are doing something like this, definitely we are helping the patient somehow that they palliate the symptoms and signs and the causes of the patient or of the problem. And here I am mentioning as a neurosurgeon, definitely we are usually putting or placing the beclophen pump placement. And when the patient is determined to have intractable spasticity despite multiple medical treatment or the suffer significant side effect from medical therapy, for example, tolerance to or over sedation from placement of beclophen. So ineffectiveness of the Botox injection sometimes helps these kind of the beclophen pump placements, and he or she is considered for continuous administration of beclophen into the lumbar subarachnoid space and delivery via the root create a lumbar to brain contraction. Here I want to mention, so the beclophen pump we are putting here, you can appreciate this in this picture. There is a pump inserted under the skin, and this pump is releasing the beclophen into the CSF, and the catheter inserted into the intrathecal space. And as I mentioned, when the patient is determined to have an intractable spasticity despite a multiple medical treatment or suffer significant side effect from the medical therapies, then definitely the tolerance to or sedation from the per-oral beclophen, and if ineffectiveness of the botulinum toxin, he or she is considered for the continuous administration of beclophen into the lumbar subarachnoid space, and the delivery via this route create a lumbar to brain concentration gradient of 4:1 and significant decrease the risk of the extraspinal beclophen side effects. Actually, patient first undergo a trial of a intrathecal beclophen injection to access for a positive response. Though the standard lumbar puncture technique, a bolus of the beclophen is injected, typically the 50 micrograms, and the clinical response graded by the modified Ashworth scale is usually seen by 2 hours and lasts up to the 6 hours. If there is a decrease in spasticity in response to the bolus, a placement subarachnoid catheter is placed in a later scheduled operation for continuous delivery of the drug. Regarding the procedure, the patient is placed in a standard lateral decubitus position with the knee moderately flexed to expand the interspinous space for the percutaneous puncture, and the attention must be made to allow adequate exposure of the abdominal area of the transverse incision necessary for the drug pump, and the side of the pump placement can be decided based on the patient's preference, or the incision should be made contralateral to the side of the external drain and the feeding tube or the colostomy, and the transverse incision is made approximately at the level of the umbilicus or slightly lower based on the size of the beclophen pump, so the blunt dissection can be performed with the surgeon's finger or the scissors, which is metronome scissors usually called, to create a subcutaneous pocket and the large enough for the pump, so the fibrous band are released with the bovie and electrocautery, and a small linear incision is made in the midline posteriorly over the L4 and L5 interspace, and the large bore spinal needle is used puncture the spinal subarachnoid space, and the spinal catheter is advanced to approximately the T10 and T12 level, and the less chance of the respiratory depression for patient with the lower extremity spasticity or to the thoracic level of the patient with upper extremity spasticity. A larger diameter catheter is tunneled under the flank to contact the drug pump to the thinner spinal catheter, and the two catheters are connected with the small metal connector and snapped or placed with the plastic securing device, or then sometimes secured with a 2-0 silk tie, and depending on the device brand, and the pump is then aspirated from the side point to check for the distal CSF flow prior to closure, and both incisions are thoroughly irrigated and closed. The pump is, and here you can see there is a small linear incision is made in the midline posteriorly over the L4 and L5 interspace. A large bore spinal needle is placed, is used to puncture the spinal subarachnoid space, and the spinal catheter is advanced to approximately T10, T12 level, and the less chances of the respiratory depression for patient with the lower extremity spasticity or to the mid-thoracic level of the patient with upper extremity spasticity. So the large diameter catheter is tunneled under the flank and to connect the drug pump to the thinner spinal catheter, and the two catheters are connected with a small metal connector and snapped in place with the plastic securing device, or sometimes secured with the 2-0 silk tie, and depending on the device brand, and the pump is then aspirated from the side part to check for the distal CSF flow prior to the closure. Both incisions are thoroughly irrigated and closed, and the pump is programmed externally to deliver continuous beclophen, typically at a starting dose of 50 to 100 micrograms per day, and gradually titrated upward based on the symptomatic improvement. So this is the, which I mentioned in front of you, the which is the beclophen pump placement. And definitely the other option we can do with the patient, the percutaneous thermal rhizotomy, and I will talk about you after this. As I mentioned, the percutaneous rhizotomy and this operation is well situated or suited for the treatment of the lower extremity spasticity in patient with the complete or near complete spinal cord lesions, or patient with the supraspinal pathology who are non-ambulatory, and it is safe and easily accessible and should be the first choice for the ablative operation. For diffuse lower extremity spasticity, rhizotomy can be completed bilaterally with L1 and from the L1 to S1, or unilaterally for the hemiplegic spasticity if spasticity recur, more invasive procedure can be considered, such as the open rhizotomy, dorsal root entry zone, we can say the rhizotomies or the mylotomies. So the technique for the cervical rhizotomy are available, but there are the limited studies on their safety and the efficacy. The procedure is typically performed under local anesthesia in prone position, and general anesthesia and or the use of the lateral decubitus position may be necessary in patient whose positioning is limited for fixed joint contracture or severe flexor spasm in the lumbar area. A 12-gauge spinal needle is inserted approximately 5 to 7 cm lateral to the midline at the level of or slightly inferior, so the target nerve root foramen, and the needle is subsequently advanced under anteroposterior fluoroscopy in an adequate fashion toward the junction of the pedicle and transfer process. Once the transfer process or lamina is reached, the needle tip is advanced ventrally and medially into the foramen adjacent to the dorsal root ganglion, and the tip of the needle should not penetrate medially to the medial aspect of the pedicle. To prevent violation of the thecal sac, the lateral X-ray is obtained to ensure that the needle tip is contained in the dorsal 1/3 of the neural foramen, and the thermistor electrode with 1 cm uninsulated dorsal 1/3 of the neural foramen, and this thermistor electrode with a 1 cm uninsulated tip is inserted through the needle and subsequently withdrawn 2 cm over the shaft of the electrode. So the 2 Hz pulse electrical stimulation is performed and the motor activity in the electrode, and then the next 2 Hz pulse electrical stimulation is performed and the motor activity in the corresponding muscle group should recover at, I want to mention here, roughly you can say, or exactly occur at less than 0.5 volt. If not, the electrode might require repositioning when the electrode is in appropriate anatomical and physiological location. A 120 seconds radiofrequency lesioning at least for the 90° centigrade is made, and this is then repeated consequently for each level of the desired rhizotomy. So this is the standard way which I mentioned in front of you. So mylotomy indication, in my humble opinion, there is a good long-term success rate are achieved with mylotomy when it is used to treat lower extremity spasticity due to the severe spinal cord etiology. However, it is a large and invasive surgical procedure when compared with the other technique, and it may be a good alternative in patient with a complete or near complete spinal cord lesion without automatic bladder function. Actually, the procedure I want to mention here, the standard midline incision in the lower thoracic spine is made based on an X-ray location, and the laminotomy or the laminectomy performed at T10 to T11 or at L1 is performed, and after the dural opening, the root of the T12 is identified by following the dorsal rootlet medially from exiting foramen, and the point where the lowest T12 dorsal rootlet and the spinal cord meet is the rostral landmark of the mylotomy. The S1 nerve root is identified by counting quadrally, and it marks the inferior extent of the mylotomy and the microscopic dissection. The posterior spinal vein and the dorsal median sulcus has been identified, and when microscopic dissection, the posterior spinal vein and the dorsal median sulcus, when you identify, the vein is preserved and retracted from the midline, and the midline sulcus is then sharply divided to a 3 millimeter depth over a 3 millimeter superior to inferior segment of the spinal cord, and the mylotomy knife with a 3 millimeter length right angle blade is inserted 4 millimeter below the spinal cord surface at the level of the central canal, and the knife needle handle is rotated 360 degrees at the lower and the upper extent of the midline in an incision, and the process is repeated every 5 millimeter between L1 to L5 subsequently, and the dura and the facial layers are closed after that in the usual meticulous fashion. Some complications are possible, and now I want to mention how you can avoid these complications and how we manage these complications. If I mention here, and you can appreciate this schematic picture, first of all, I want to tell about the mylotomy. Given the invasive nature of this procedure, the inherent risks include the worsening sensory or motor deficit and the CSF leak, infection, post-operative pain. Careful patient selection is critical and should be reserved for the patient with the severe, I want to say, the spinal cord pathology with complete or near complete loss of the lower extremity motor and sensory function, and without preserved autonomic bladder function. When we are doing the percutaneous thermal rhizotomy, the complications are rare and may include infection or worsening of the sensory or the motor function in intact patient. However, the most patients undergoing thermal rhizotomy for spasticity have severe deficit at a baseline, and some doctors or surgeons have noticed that the high recurrence rate usually with the percutaneous thermal rhizotomy. So maybe we need to repeat the procedure, or we have to go for the mylotomy, or definitely we have to consider the other option. But operation can be repeated a second time without any difficulty. For the beclophen pump, the most common complication associated with the beclophen pump placement are breakage or the blockage of the spinal catheter and drug overdose. Thus, meticulous technique is when connecting and securing the spinal catheter to the distal pump catheter is critical. So attention must be focused on removing of the spinal needle from the catheter is critical, and attention must be focused on removing the spinal needle from the intrathecal space in a fashion that will not shear or injure the spinal catheter. Pump failure can cause beclophen withdrawal, which is associated with headache, severe worsening spasticity, seizures, cardiac instability, and pruritus. So temporize with the IV or the per-oral beclophen and the benzodiazepine. So the drug overdose can lead to the nausea, emesis, dizziness, weakness, or I must say over sedation. So these symptoms can be addressed by, I want to mention here, reprogramming the pump to a lower delivery rate and the severe overdosage can lead to respiratory depression and coma, and these patients must receive immediate ventilatory support, have their pump and rate decrease or amputized, and may be treated with the I want to have physostigmine. Care must be taken to start at the low delivery rate and gradually titrate upward, and I want to say here infrequently, and a granuloma can occur at the tip of the catheter. If asymptomatic, then the stopping of the pump will usually resolve the granuloma. However, if severe symptoms are evident, so some advocate the decompression, especially with the mass effect. So this is all we can take care for this, and for now I want to wrap up this topic, and if I feel there is some more details regarding this topic, then I will present with the separate case. So thank you so much, and support us, like us, and share these videos with your friends and your patients. Thank you so much.